Welcome to AETCM, the emergency medicine channel. Today let us discuss about respiratory failure and one of the most important clinical sign, that is cyanosis. We know that whenever we have breathing difficulty, like you have asthma, COPD, pulmonary edema, whatever it is, you can see the patient's fingers and tongue, lips all are becoming blue. That is because the blood which contains oxygen and carbon dioxide, the levels of the carbon dioxide is increased due to conditions like COPD, asthma, ILD or pulmonary edema, cardiac failure, whatever it is. If the carbon dioxide levels are unusually high, it gives blue color to skin and mucous membrane, that is cyanosis. So you can see here a patient who is having cyanosis, lips are blue, tongue is blue, hands are blue, sometimes the whole body itself will be blue. That commonly seen in congenital heart diseases, that is cyanotic congenital heart diseases, or reversal of shunt in some acyanotic congenital heart diseases. You can see the whole body will be blue. Blue color is due to reduced hemoglobin. That means it does not have adequate oxygen, it is mainly containing carbon dioxide. So when we see the circulation, you can see arteries are red in color, veins are blue in color, because vein contains more desaturated blood. That means the oxygen content in the blood which is carrying through the veins are less and carbon dioxide levels are high there. So that gives blue color to veins. So definition of cyanosis is bluish discoloration of skin and mucosa resulting from an increased level of reduced hemoglobin. That means oxygen content is low, carbon dioxide content is high, or due to abnormal hemoglobin pigments like methemoglobin, sulfhemoglobin. They are actually they are abnormal hemoglobins. They give blue color to blood and skin mucosa. Here actually oxygenation is not defective, the hemoglobin itself is defective. Cyanosis is mainly divided into two important types. One is central cyanosis, other one is peripheral cyanosis. Most of the conditions like cardiac disease, lung disease, they produce both central cyanosis and peripheral cyanosis, or throughout the body it will be cyanosed. Whereas some conditions where they produce peripheral vasoconstriction like Reynolds phenomenon or vascular injury and producing focal vascular obstruction, they produce focal cyanosis. That means only peripheral part will be cyanosed. And conditions like cardiac failure, patient can have initially vasoconstriction to compensate the cardiac failure. That time initially you can see only peripheral cyanosis, but ultimately patient develops central cyanosis even in cardiac failure. So central cyanosis means it is due to circulatory or ventilatory defect. It can be a defect in the heart, pumping is defective, so that there will be increased pressure in the pulmonary circulation. Patient can have pulmonary edema and oxygenation will be reduced, or a lung disease like COPD, asthma, where there is defective oxygenation in the lungs and defective oxygen circulation in the lungs, that produces low oxygen infiltration to the blood or low oxygen diffusion into the blood, that produces hypoxemia and produces cyanosis. So low oxygen is produced during cardiac failure or lung failure. Cardiac causes for central cyanosis are mainly left ventricular failure. So whenever we practice in emergency room, we can see most of the patients coming with left ventricular failure, pulmonary edema, they will be cyanosed. That is the most common cause for cardiac failure. But in children, it can be due to congenital heart diseases like tetralogy of Fallot, shunt reversal in congenital heart diseases, that is called as Eisenmenger syndrome. Eisenmenger syndrome means you have ASD or VSD, but initially ASD or VSD will not produce cyanosis, but after sometimes after pulmonary hypertension develops, the shunt will reverse and patient develops cyanosis. So basically congenital heart diseases are classified into cyanotic and acyanotic heart diseases. Cyanotic heart diseases, they initially itself patient will be cyanosed. Acyanotic heart diseases, after some time reversal of shunt, patient develop cyanosis. This is called as Eisenmenger syndrome. Veno-arterial shunt also can produce like cyanosis in patients. Respiratory conditions, mainly asthma, COPD, pneumothorax, pneumonia, ILD, any condition which reduces the oxygen diffusion to the diffusion capacity is reduced, that can produce cyanosis. But commonest thing what we see in our practice will be COPD and asthma. Now, peripheral cyanosis means patient's peripheral part, hands are cyanosed. This is classically observed in condition which is called as Reynolds phenomenon. You can see Reynolds phenomenon is a focal vasospastic condition. Peripheral circulation, you can have vasospasm. Initially, there will be during vasospasm, you can see the fingers are pale. After sometimes it will be cyanosed. Then during rewarming, it will be red in color. So, peripheral cyanosis can be produced by Reynolds phenomenon or Reynolds syndrome. Reynolds phenomenon can be primary as a part of Reynolds syndrome itself, or secondary Reynolds syndrome can be seen in conditions like scleroderma, SLE, and other rheumatological conditions. Mixed cyanosis, you can see both peripheral and central cyanosis. One classical example for mixed cyanosis, like patient who is having cardiac failure, left ventricular failure. Initially, you can see the patient is having during the initial phase of cardiac failure, there will be vasoconstriction in the peripheral circulation that produces some cyanosis in the fingers. Afterwards, patient develops central cyanosis also. So, patient can have, when the patient come to emergency room, we can see both peripheral and central cyanosis there. That is due to pulmonary edema produces central cyanosis and peripheral vasoconstriction produces peripheral cyanosis. So, mixed cyanosis is always a feature of cardiac failure. Differential diagnosis is a rare condition. You get in some part of the body will be red, some part of the body will be blue. Conditions like patent ductus arteriosus, you can see the first picture, patent ductus arteriosis, bluish discoloration of the lower limbs. Lower limbs will be bluish discoloration because after the like patent ductus arteriosis, blood will be mixed with venous blood, and that produces blue color in the lower limbs, and upper limbs and head will be red in color because before the patent PDA that supplies the head and upper limbs. That's why upper part will be red and lower part will be blue. Reversed differential diagnosis means after sometimes the flow will be reversed, so that produces upper limb will be cyanosed, lower limb will be not cyanosed, seen in transposition of great vessels and patent ductus arteriosus with reversal of shunt. Now, when we talk about cyanosis, we will see what happens inside our body. So, we already discussed that when there is cyanosis, the blood is full of carbon dioxide, not with oxygen. So, normally our oxygen in our hemoglobin, oxygen levels are higher than carbon dioxide, but here carbon dioxide levels are higher than oxygen. So, we will see what are the different types of hypoxemia and hypercarbias and other conditions. Hypoxia means PaO2 less than 80 millimeter of mercury. Causes are right to left shunt, hypoventilation syndromes, impaired diffusion in the lungs, ventilation perfusion mismatch. So many conditions can produce all these problems. You can see asthma, COPD, pneumonia, pulmonary embolism, pneumothorax, pleural effusion. So many conditions and congenital heart diseases and conditions like chronic lung disease can also, chronic liver disease also sometimes can produce shunting in the lungs. This is called as hepatopulmonary syndrome. So many conditions can produce hypoxemia. Hypercapnia means PaCO2 more than 45 millimeter of mercury. Carbon dioxide narcosis means PaCO2 more than 90 millimeter of mercury, and patient develops altered behavior and coma, seizures like that. Causes are increased CO2 production, hypoventilation, increased airway resistance, ventilation perfusion mismatch. So if you see the common causes in emergency room which can produce all these things, one is acute exacerbation of asthma, acute exacerbation of COPD, left ventricular failure. These are the most important causes what we see in our clinical practice. But other conditions like pulmonary embolism, pneumothorax, or congenital heart diseases, all these things are there. The list is very big, so we will not be able to tell everything. Now, when we talk about respiratory failure, that means our normal physiology is changed. Due to some problem, the normal physiology is changed. We can see there are 4 types of respiratory failure: type 1, type 2, type 3, type 4. The major types are type 1 and type 2. Type 1 means hypoxemia is there. Oxygen levels are low, but carbon dioxide is not built up. Carbon dioxide is not increased. The commonest conditions are acute asthma, pneumothorax, pneumonia, acute pulmonary embolism, acute ARDS, pulmonary edema. You can see all these things are acute. So within a span of time, patient will come to emergency room. When we see the oxygenation, that is low. But if you take the ABG, carbon dioxide levels are not very high. That means you can see here PaO2 is reduced, PaCO2 is normal or slightly reduced, pH is always normal and slightly towards the acidotic range. HCO3, that is bicarbonate, is normal. So there is no problem other than PaO2 reduction. Any acute breathlessness, you can see the oxygen levels are slightly low. But whereas chronic conditions, oxygen is reduced, CO2 is also normal, pH is normal, bicarbonate is normal. In type 1 respiratory failure like chronic asthma or chronic pulmonary embolism, most of the times patients are well preserved. They will not have any feature of hypercarbia. They will have only feature of mild hypoxemia. So other than hypoxemia, they will not have any other problem. But in clinical practice, the most important things in emergency room are acute type 1 respiratory failure. Now we will see what is type 2 respiratory failure. Here a little more complicated thing. You can see PaO2 is reduced, oxygenation is reduced due to some condition, and slowly we can see the carbon dioxide is building up. Carbon dioxide removal from our body is defective and carbon dioxide is building up. But we have to think that when the carbon dioxide increases like that, it can produce acidosis, because carbonic acid produces acidosis in our body. So you can see acidosis. Then after some times, to compensate that, our bicarbonate levels also will increase. By kidneys it will increase. So acute type 2 respiratory failure, tracheal obstruction, massive pneumothorax, massive hemothorax, drugs like diazepam overdose, opiate overdose, brainstem stroke, Guillain-Barré syndrome like muscle weakness, poliomyelitis, all these things. But the commonest diseases are chronic type 2 respiratory failure, that is COPD and central sleep apnea syndrome. These are the 2 important conditions which come to emergency room, like COPD with acute exacerbation, central sleep apnea syndrome, or peripheral. Sleep apnea syndrome altogether can be taken central or peripheral. We will not discuss now. So sleep apnea syndromes can also present to emergency room. Both these conditions, you can see the ABG. If it is an acute condition, PaO2 is reduced, PaCO2 is slightly elevated, pH is reduced. But you can see compensation has not occurred. Bicarbonate levels are normal. But whereas in chronic condition, body will try to compensate for this carbonic acid. You can see PaCO2 is elevated, carbonic acid is elevated. To compensate that and to maintain the pH in normal level, body will try to compensate through the kidneys. Bicarbonate levels also, you can see that is also increased. So the pH will come to near normal. It will never cross to the opposite side. That means even if the bicarbonate is retained like this by kidney, it will never go to the opposite side. That means it will never go to 7 point. It is like if it is less than 3.5, it is acidosis. Less than more than 4.5, it is alkalosis. So it will be somewhere around 3.5 to 4. It will never cross to 4 and above. That means if it is going to alkalotic side, some other acid base problem is there in that patient. So always remember, it will become near normal. Now type 3 and type 4 are there for theory purpose. We should remember respiratory failure of type 3, that is perioperative respiratory failure. that can be seen in surgical wards. Type 4 is very common, but the mechanism of hypoxemia is different. It is in shock. It describes patients who have intubated and ventilated in the process of resuscitation for shock. So these two types of respiratory failure, clinically they are not very significant. So the treatment aspects for type 1, type 2 are very important, but type 3, type 4 is just like treating type 1 and type 2. That alone is enough, and you can remove the problem. That is, a precipitating problems are very important in type 3 and type 4. Now, normal ABG values you can take from this chart. PaO2, that is 95 plus or minus 5, PaCO2 40 plus or minus 2, SaO2 saturation, that is 97% plus or minus 2, pH, always remember 7.35 to 7.45. If it is less than 7.35, it is acidosis. More than 7.45, it is alkalosis. Normally in hypoxemia, pH will not change, but acute hypercarbia also pH will not change. But in chronic hypercarbia, pH will go to acidotic side because of carbonic acid, and after sometimes body will try to retain bicarbonate and it will go to the alkalotic side, but it will never cross the middle of the pH. That means it will not go to 7.45, that range it will not go. Base excess, you can see it is plus or minus 2. So these are the common ABG values what you are going to get in patients who is having respiratory disorder, or when we are treating a respiratory disorder case, normal ABG values. Now in respiratory acidosis, what will happen to the patient? We will see respiratory failure. You can see that is in type 2 respiratory failure we are discussing. In type 2 respiratory failure, we can get hypoxemia and hypercarbia. PaCO2 is going to increase. So you can see the formula here. PaCO2 is increased, and what happens to the pH? pH reduces. That is, we call it as respiratory acidosis. So PaCO2 is increased, pH is reduced. But after sometimes what happens is patient develops slowly bicarbonate will be retained in the body by kidney, and that produces compensation. We will see what is the compensation. You can see here compensation occurs like that. Whenever there is respiratory acidosis, you can see here pH, initially pH reduces, and kidneys, hydrogen ion loss in the kidney through the urine. So hydrogen ion is lost and bicarbonate is generated in the kidneys. That both hydrogen ion loss and bicarbonate retention can produce compensation, and the pH will go towards the alkalotic end, but it will never cross to the opposite side. It will never produce an alkalosis. It will be always in the range of the normal pH. Acute respiratory acidosis, you can calculate bicarbonate, that is PaCO2 minus 40 by 10 plus 24. Chronic, it is PaCO2 minus 40 by 3, that is divided by 3 plus 24. We can calculate this compensation of bicarbonate from the PaCO2 and PaCO2 itself, and see the clinical scenario whether it is an acute respiratory failure or chronic respiratory failure. This is very important because same patient can have two acid-based disorders. Like a patient can have lactic acidosis with hypoxemia and hypercarbia producing respiratory acidosis. So if you want to know the compensation is actual compensation, or if the patient is having another alkalotic disorder like hypokalemic alkalosis, then sometimes in multiple acid-based disorders we will have to calculate what is the expected correction of the bicarbonate, so that these formulas are required. Otherwise, in routine clinical practice, like a patient who is coming with respiratory acidosis, who is having pH low and compensation is there, this type of calculations are not required. But if there is an additional acid-based disorder like lactic acidosis or metabolic alkalosis like hypokalemic alkalosis, then these formulas are very important, so that we can calculate and see whether there is a proper expected correction of bicarbonate is done or not, or if it is more or less we can calculate. So, acute respiratory acidosis and chronic respiratory acidosis, we have seen why this compensation occurs, what is the range of compensation we can see here. For acute respiratory acidosis, you can see CO2 when it is increased 10, you can see bicarbonate will increase by +1, and chronic respiratory acidosis when it is PaCO2 increases by 10, bicarbonate increase by +4. So, if you remember this, at least this previous formula will be difficult for anyone, but if you remember like this, it will be very useful. For every 10, +1 for acute respiratory acidosis and +4 for chronic respiratory acidosis, that is a correction formula. Then if it is more than this, suppose the bicarbonate correction is more than this expected correction, you have to think about some other additional acid-base disorders. So, ABG will be always helpful to make out additional acid-base disorders, because in a respiratory acidosis due to COPD, even without an ABG itself, clinically you can make out whether the patient is going for respiratory acidosis, carbon dioxide narcosis, whatever it is. If the saturation is very low, you treat according to patient's clinical scenario, like you can give oxygen, you can give nebulizations, you can give magnesium sulfate infusion. Some patients may require aminophylline infusion. If the patient improves with your initial treatment, ABG itself may not be required for additional ABG, may not be required for this type of patients. But if the patient deteriorates, like a patient is having additional lactic acidosis, then you need to take repeat ABG and you have to find out what other acid-base abnormality is there for the patient. So, these things are very important when you are treating complicated cases. Now, one important clinical examination finding I just wanted to tell: a patient who is having carbon dioxide narcosis or hypoxemic encephalopathy, you can see in most of the encephalopathy, like metabolic encephalopathies like chronic liver disease, hepatic encephalopathy, chronic kidney disease, uremic encephalopathy, some toxin-induced encephalopathy, toxic encephalopathy, and here also hypoxemic encephalopathy. There also you can see flapping tremors. In flapping tremors, actually you have to ask the patient to hold the hand like this. You can see the hands should be like this, hands like this, and you can see the hands are flapping. Flapping means it is going like this, down like this, go down. But don't think that it is always going down like this. It will be going up and down. That is because whenever we ask the patient to hold like this, you can see there is a connection from your joint to your brain. This is interrupted. These joint connections to the brain are interrupted in encephalopathy. That's why patient develops flapping tremor. This is one of the easiest thing you can make out in emergency room, whether the patient is having encephalopathy or not. Even without an ABG, you can easily pick up whether the patient is going for carbon dioxide narcosis or hypoxic encephalopathy only with this clinical finding. But remember, many patients who is having difficulty in breathing, they are agitated, they are anxious, will not be able to do all these tests. So, whenever the patient come to emergency room with cyanosis, only thing you have to make out whether it's a cardiac case or a respiratory case. Remember, in cardiac failure, patients' peripheries are always cold because of the peripheral vasoconstriction. But in patients who is having respiratory disease like COPD, their peripheries are always warm because carbon dioxide, persistent elevation in the carbon dioxide produces peripheral vasodilation. So, if you are seeing a warm peripheries with cyanosis, most of the time it is due to COPD and respiratory failure. If you are getting a cold periphery with cyanosis, then it is a cardiac disease. Whereas patient who is having peripheral cyanosis during cold weather, then it is due to Reynolds syndrome. So, all this differential diagnosis you have to make out during acute exacerbation of breathlessness. So, we have discussed about one of the important condition in emergency room, that is cyanosis. So, cyanosis, anybody can pick up cyanosis in emergency room because it's a very obvious blue color change in your tongue, lips and hands. So, when the tongues and lips are involved, it is central cyanosis. When the hands are involved, peripheral cyanosis. But in routine clinical practice, whenever we practice in emergency room, you can see cyanosis can be due to cardiac failure, cyanosis are due to COPD with exacerbation, cyanosis due to asthma. All these conditions you can see both central cyanosis and peripheral cyanosis is there. Isolated peripheral cyanosis is mainly seen in peripheral vascular obstructive lesion. It can be due to Reynolds phenomenon, it can be due to atherosclerotic lesion in the peripheral blood vessels. So all these things can be there. So we have discussed one of the important conditions, that is cyanosis and respiratory failure. Thank you.